So good morning and welcome everyone to this year's Southeast England Faith Forums Conference, Grief and Faith in the Time of COVID. It has been a roller coaster of a year and a half since March 2020, an unprecedented and challenging time. It is times like this, our resilience, our patience, our faith, and our service to others is really tested. And we have many unsung heroes to be thankful to and for. Today, we are going to hear from some amazing speakers who can shed light on how COVID-19 has impacted their work and share their experiences. In the afternoon, we will hear from Dr. Joanna Collicutt in more detail about avoiding science, with a focus on faith communities. But let us begin, as is tradition, with a minute of silence and reflection on today's topics. And then I'd like to invite Dr. Harriet Crabtree to begin first, as Dr. Suhil Bhatti and Jamie Green are not here with us, so I'm just going to shift the program around slightly. So let's first begin with our Thank you, everyone. So I'd like to invite Dr. Harriet Crabtree, who is the Executive Director of Interfaith Network UK, to begin with some opening reflections.
Thank you so much, and thank you for the kind invitation to participate in today's conference. I'm just going to, if I may, warn you that they've decided to cut down some very large trees a little behind my house, which is not very environmental, and it is a little noisy, so please forgive me if you hear any noise. I'm going to offer a few reflections, if I may, on faith communities and COVID in the context of the topic of the day. But more generally also, because I think faith communities have played the most astonishing role during the pandemic. And both in relation to some of the amazing response that they've made on the kind of assisting people in need front, but also dealing with the pastoral issues. I will use something of a written note, but I'm also just going to offer some reflections and I go, and I believe I have 10 minutes, is that correct? Right, okay. So I suppose the immediate impact of COVID was that faith communities stepped up. They stepped up very rapidly and they responded to the needs of their own congregations, but they also responded to the wider community needs. And it now seems almost impossible looking back, the speed at which people did move and the frightenedness, the real anxiety with which they were dealing. So nearly every national faith community immediately began to produce its own guidance. It was each one of them was dealing with things like places of worship, but also, and the safety of those, and then with the restrictions, but they were also dealing with the fact that many people were ill, and furthermore, quite a number were dying, with a disproportionate impact on particular communities for reasons that still remain subject to some debate. but this was a very fundamental difference between communities at that time. And you may recall that a number of communities were disproportionately represented immediately within the doctors and nurses dying. You'll correct me if I'm wrong, but I think the first 4 or 5 doctors to die were from the Muslim community. Is that correct? And then there were other people like the leading Sikh A&E consultant, who I recall sadly dying at some point during the pandemic. And nurses and many others were affected, and of course, ordinary congregation members. So faith communities had to do several things simultaneously. They had to deal with the challenges of illness, the challenges of death, and preparing people for funerals, etc., in a context where few people could attend. The most fundamental human instincts to be present when somebody was dying, to be present at the funeral, to give thanks and remember the person, absolutely undercut by this terrible period of restrictions and illness. So there was a great pastoral requirement for every faith community. And likewise, I think there was I don't know quite what the correct term is, it's not exactly social action as such, but all communities swung into action to support not just the needs of their own, but also people more widely at a local level. And on top of the formal faith community initiatives, things like, for example, the Salvation Army's work, and every community had structured work, there were, of course, many others who were inspired by their faith to take part in initiatives run by things like Severde, or Sikh institutions and others who brought particular types of food and forms of support to frontline workers. Mitzvah Day, a range of others, every single faith community, people from every faith and belief. So there were 2 things going on simultaneously throughout the pandemic: responding to pastoral need, death, grief, loneliness, anxiety, responding to help people in often desperate situations. And all of those things were happening as faith communities were also seeking to give input, for example, to local authority emergency response, to national programs, looking at things like vaccinations. So many things happening simultaneously, and all at a time when people were trying to get to grips with digital engagement for the first time. How many of you on the call in this meeting today used Zoom for the first time when the pandemic began? How many of you for the first time used Skype? And how many of you for the first time actually used smartphones for day-to-day business? So a range of different things. What one saw was this quite different pattern. How many people here are faith leaders today who have a community responsibility with a place of worship? Did you for the first time during the pandemic stream your services? Such a change. And the place, though, that I think, particularly in terms of today's very important discussions, the place where it was hardest to deal with many of these things digitally was in the pastoral context. It's so hard to reach out to somebody just by telephone or by Zoom. And I participated in one live streamed funeral, and it was a reminder of just, the difficulties, the sadness of that. I remember there was a Hindu gentleman from Leicester who wrote in the local paper about how distressed people were that they couldn't undertake the usual burial preparations and rituals, and every community had that. Nonetheless, I'd like to just use the last few minutes to talk about some positives that I believe came out of this very difficult period, which of course is still with us. We shouldn't be too optimistic, I think, that it's in the past. We still have people with cases quite high. We obviously have less hospitalization, but it's still affecting our lives. But closing on the positives, I was amazed really by the speed at which this pandemic threw people together and led faith communities to work more closely together. I don't know how it's been in your region and whether you've all experienced this the same way or differently, But I saw at national level faith communities talking with each other more frequently. We held much more regular meetings of Interfaith Network's Faith Communities Forum, which brings together the national faith community bodies. And they talked about the places of worship. They talked about how they were responding to local communities. There was a real sharing and learning. This wasn't always very well structured across every region or nationally. You had different approaches. The local resilience forums did their best, but you had some places were stronger than others in terms of this. But the fundamental point that I would finish on is that the pandemic proved to be harrowing. It has proved to be harrowing and yet inspiring. And it has also brought people together in new ways. We don't know where we're heading on the digital, hybrid and in-person front. We're all wrestling with that. But what we do know is we've made more connections, I think. So I choose to rest, if I may, Chair, on this positive point, that out of sorrow and difficulty, there has also come some learning that may be positive for the future. Thank you.
That's great. Thank you, Harriet, for stepping in as well and setting the scene for us. So we are going to change the program around slightly because we're still waiting for Dr. Suhil Bhatti. I believe Jamie Green is now here. Thank you for joining us. But I'm going to go to our other two speakers first, Jason Messer and David Knight, to cover the dignity element of our conference today, and then we'll come back on to care later. So I would now like to invite Jamie Green, who is the chair, sorry, I would like to invite Jason Mather, Head of Client Services, Citizens Advice in West Sussex, and I will help you with sharing the screen. So if you could unmute yourself, please.
Good morning, everyone, and thank you for inviting me along today. Coulter's going to help me with some slides, which will guide my overview of the work that we did in Crawley, and I will send through the full report that was compiled as a result of this first piece of work through to Coulter, and she can distribute it amongst the group later on. So next slide, please. So within COVID and as a result of the Runnymede report last year, which showed very clearly that there was a disproportionate impact on people from a Black, Asian and minority ethnic background, we were commissioned locally by the NHS to take part in community engagement work, along with Brighton and Hastings towns, so that we could gain insight and come forward with recommendations based on what they had told us. In Crawley, the commissioners were struggling to find someone to deliver this piece of work, and we were approached and we thought about it very carefully, and we decided that it was right for us to do it because we're deeply embedded in the community in Crawley, and people trust us that we have a neutral voice and we will make good representations on their behalf. So the first project explored the disparity of COVID-19 on the community in Crawley. For this project, and a lot of it was done digitally, so picking up on what the comments that we just made, we had to really boost our digital activity to reach people because people were still scared about coming out. There was lots of restrictions in place, and it was difficult to engage. So we had 214 comprehensive surveys which were online and in paper. We conducted 22 semi-structured interviews, 8 in-depth ethnographical interviews, 3 focus groups, and we reached out to nearly 30,000 people on social media. We also use boost samples to improve representation, for example, for newly arrived migrants in Crawley. The in-depth interviews took ethnographical principles, exploring culture and lifestyle, values and experiences in the home setting via video calling. Focus groups were explored, and we tested emerging themes with online open style forums. In addition to this, we formed an advisory group made up of professionals working in the area and mixed Black, Asian and minority ethnic backgrounds to provide input and feedback throughout the project and report writing. And what followed on from that piece of work and the report, which I will circulate after, was the NHS commissioners recognised that further inclusion work was required because our findings were, so important, and the community were talking to us. So they essentially extended the project to cover another piece of inclusion work. And a lot of that was done through a proper lockdown. So again, we had 89 survey responses, 21 semi-structured interviews, 68 informal interviews, 95 reached directly, and about 28,000 people reached on social media. Can I have the next slide, please? Can I have the next slide, please? We've frozen. Okay. So the insights that we found, and the idea was that we would talk to the communities, get, find the insights, look at the emerging themes, and then come forward with recommendations that were put not only to the NHS directly, but to all system leaders in Crawley. And we've done a lot of work with Crawley Borough Council and other system leaders in Crawley, so that these views are and insights are being heard at a systemic level. So we found that there were big information gaps. It was expressed by the community members that a lack of information and translations on accessing COVID tests, information regarding vaccine and other services. For example, through the engagement, we found an individual in the refugee community who was unaware of the existence of 999 and how the system operated if they were in need. Information gaps were also further increased by language and communication barriers. To illustrate through engagement, it had been identified that some groups were reluctant in accessing healthcare purely because they were unaware how to use translated services. And we also found evidence that using automated services for people with English as a second language could be problematical, and they knew that the network had told them if you call 999, you might have a better chance of getting hold of a translator, which is a terrible state of affairs, really. There were further worries about access to healthcare and other support services. It became quite clear that the community members were more likely to be exposed to COVID-19 through frontline work in Crawley. Another insight we found during the engagement was that whilst the community do have trust in the NHS and they were very positive about the NHS, there was a lack of trust in the government. Overwhelmingly, people were very positive about the NHS once they'd accessed the services. For example, several people mentioned there was a suspicion from a government level. There was a suspicion amongst African communities towards the vaccine, with one participant expressing that the community worry was that the government would test the vaccine on them first, seeing them as guinea pigs. Slide 3, please. So after carrying out the research, we came up with the following recommendations, which were put to the NHS. That there was a need for wider and ongoing engagement to build on the previous work in order to implement change. Continuous engagement with the community will help organisations build knowledge and become aware of conversations within the community that allow us to provide reassurance. For example, several community members from different groups have shared rumours which circulated regarding the COVID vaccine, including how it can change genetics and infertility. We're able to break those conversations down if we ongoing community engagement happens. Improvements required to the quality of information, accessibility of services must be measurable and communicated to communities in Crawley. Setting out the key activities and keeping members up to date on progress and involving them where possible. We've taken this approach ourselves with the advisory group we've created in Crawley, which has allowed us to build trust within the communities, and as a result can prevent individuals from seeking information and being influenced from sources of misinformation. If they're unable to access information in the UK, we saw lots of evidence of them accessing and relying on misinformation from abroad. Information needs to be easy and clear to navigate, accessible, and includes using plain and simple English for resources. So an example of that is using words that can easily be translated. Lots of people picking up on what Hilary said about using digital phones for accessing, information. Translation things on Google are only good if the word exists and it can be translated and the sentence is very simple, so that it can actually translate it so that it can be made sense of. Use a blended approach to share messages, such as using videos and champions rather than relying on pure written communication. It's important to make official NHS resources as phone friendly and as shareable, as it will increase the amount of accurate information shared. For example, one of the community members told us that if positive messages were created by trusted bodies that could be shared via WhatsApp and other social media platforms, it would go a long way. This is because those platforms are used widely by diverse communities, and sharing messages in this way can overcome rumours and what have you. Early support with issues outside of health are needed to prevent widening health and social inequalities. One thing that came very strongly through the surveys we did in the first project, that people were desperately worried in Crawley about money, employment and housing, which of course will have an impact on their health. As a result of that report, we were able to find some funding from West Sussex County Council for a community-based money advisor, and that's been really well received by the community. Also, the last recommendation was to improve relationships and communications between healthcare settings and the community. For example, sharing up-to-date knowledge of what is available, how to navigate the system, tips on working with your healthcare professionals, and the wider support that's available will all increase the confidence and ensure people get the help that they need. Next slide, please. So really that was the launch pad for a number of pieces of work that we're involved with now. So the advisory group and the champions approach we were commissioned to deliver that again in Mid Sussex and Adrian Worthing by the district councils. They've really seized the opportunity and seen the impact having the community champions can have. And we also had been commissioned by the NHS to engage with, there's a high incidence of lung cancer in Crawley amongst the Black, Asian and minority ethnic community. So we have been commissioned to deliver a piece of engagement, insight and awareness work around lung cancer. And that's very much working closely with a group of GP practices and system leaders in Crawley. So that's where we are now, and I'm more than happy to send through the initial report to you all. It makes for a fascinating read and captures a lot of stories, and it gives you a context, a much better context around this whole area. I hope you have found this useful, and I look forward to hearing the other speakers. Thank you.
That's great. Thank you, Jason. I found it really interesting, especially since, you know, myself having worked with ethnic minority communities and linking up with faith communities, and I think most people here will have that sort of link. And I think communication is key. And for me, what came out was making sure that messages are available in different formats through social media, but also through different people. So if it was coming through Surrey County Council, there's a lot of people that are going to be missed who, you know, who don't follow Surrey County Council. So we had a good working relationship with faith communities and the council. The council would pass on the information to the faith leaders, and then the faith leaders would pass it on to their congregations. So there's different ways around it. And I think COVID really highlighted that relationship and the importance of maintaining that relationship. So thank you very much, Jason. Let's move on to, and if anybody has questions, please do put them in the chat. Emil and David are making a note of your questions, and we'll go through them later on. So let's move on now to Dr. David Knight, who is the Special Care Lead, Sussex Community NHS Foundation Trust, and he's going to be talking about end-of-life care and faith.
Thank you. Thanks for your invitation, and thank you for being here in abundance to hear us all speak. I'm very grateful to Harriet and Jason for what they've said. Harriet in particular for pointing out the disproportionate impact of the pandemic we're still experiencing on different communities within our country. And I'm also grateful to Jason. I suspect I'm going to be hearing quite a bit more about that report, Jason, because the NHS trust I work for is the Sussex Community NHS Trust, and we have quite a few wards at Crawley Hospital. And so I suspect we've been quite intimately involved in the commissioning of your work, and I know we're going to benefit from it. Thank you. I've been asked to talk about end-of-life care and faith in the context of the pandemic we continue to experience. And that is a huge topic area, and so I've decided to refine it down a little bit. So I won't be commenting on the experience of end-of-life care in community settings. What I am going to focus on is how it's felt as somebody working within the NHS, how this journey has felt as we've tried to negotiate end-of-life care in our institutions under an unprecedented pressure. First thing to say is that the UK is widely understood globally to be the world leader in end-of-life care. We can be rightly proud in having trailblazed both through the hospice movement and through the development of the medical specialism of palliative care, unparalleled quality in our end-of-life care. The four pillars of end-of-life care, good quality end-of-life care, physical care, emotional or psychological care, social care, and spiritual care, those four elements now constitute the World Health Organization definition and are the standard across the globe, and they were developed in the UK. Spiritual care in particular is the one I'm going to focus on around end-of-life care because of its obvious relationship to individual faith. It's something that we can be proud of, that spiritual care is a standard part of practice within the NHS and within the hospice movement is now pretty much unremarkable. You would be hard pressed to find a nursing, medical or other healthcare team operating within a hospital or a hospice that did not understand the importance of access to faith expressions, both ritually or access to maybe to a faith leader in end-of-life care. And the shock of the pandemic for those of us involved in the internal workings of healthcare was that that standard practice, that fully embedded notion of access to the expression of faith at the end of life, stumbled badly. We had stories, and I'm sure you're aware of them, of people ending their lives alone, without somebody with them who could share them or help them express their faith, certainly without access to a faith leader, in many cases, in many units, without even access to the paid spiritual care service, chaplaincy service employed by that healthcare trust. And the reason for this, of course, was the overwhelming priority of trying to attend to the risk of transmission of disease. I don't think it's too extreme to say that we suddenly found ourselves approaching a war footing. The NHS is remarkable in its control, national control and command structures, which are so easily adjusted to meet national crises. But even given that impressive national capability, we were struggling to attend to, understand, cope with an unprecedented set of pressures, a perfect storm of pressures. At the end of the first lockdown, and memories blur here now, I've honestly lost track of how many lockdowns we've had now, but certainly in the early stages of these pressures on healthcare resources and the isolation of healthcare units and wards, there was ongoing reflection and learning while this was happening. And that, I think, is one of the most impressive things I've experienced within the system, the preparedness to learn quickly and to adapt and just to do your damn best to cope and try and make it as good as you could for the patients. And one of the things that was learned quite early on and was remarked on by the Royal College of Nursing and other professional bodies was that we'd overdone it on isolation. We'd overdone it. And we'd strayed into areas that felt inhumane. And the two areas of care in particular where we felt we'd overdone the isolation, one was end-of-life care, and the other was maternity. And we've all heard stories of mums finding themselves utterly isolated while they were giving birth. And end-of-life care too, it became apparent so quickly how unwittingly we'd created pain for people and for their families. So the Rcn report, and this has been accepted, as far as I can see by talking to colleagues pretty much across the board now, future lockdowns will not involve restricting access to people at end-of-life care for family members within reason and faith leaders. That's been a wonderful learning and one that's been acted on really pretty quickly. So coming towards the end of my 10-minute slots with a vast theme and hopefully just having provided you with a flavour of how it's felt internally, I'm optimistic about the NHS's ability to adapt to challenging circumstance, and I'm particularly optimistic about our new settlement in caring for people at the end of life within the ongoing challenges of a national pandemic. And I'm certainly confident that from all of this learning, as we reflect on it over the coming months and years, we will do the whole thing a lot better next time. Thank you.
Thank you, David. Very insightful, and totally get where you're coming from with the maternity services and within the care home setting as well. Very difficult. It has been a really difficult time, and it probably still is a very difficult time. So thank you so much. Two of our early speakers are now with us. Just looking at the time, it's now 10:40. I think I'd like to give 10 minutes to our Q&A session for the three speakers that we've heard from, so that we can get a better discussions going. So if anybody has any questions to either Harriet, to David, or Jason, please put them in the chat. I think David and Emil, if you have any questions, please do share them now, and then we'll invite our other two speakers.
So far, we haven't got any questions in the chat area, but I would like to ask Harriet how we coordinated with the interfaith organizations all around the UK. We were talking about the lack of electronic capabilities. Most of us didn't know how to use Zoom and etc. How did we do all this coordination? They did immensely good work in reaching out to people and supplying government all the faith information about the sacred spaces and etc. Could we briefly hear from that?
Emma, I'm so sorry that I didn't quite hear the very first part of your question. Could you just ask me in one sentence the key question again? Forgive me. Just in brief, what is the question?
How did you organize the coordination between the organizations in interfaith organizations all around the UK, finding out how do they deal with that crisis?
Well, I think IFN, thank you for your question. The Interfaith Network doesn't coordinate people's response as such, but what we did do was we regularly gathered continually through particularly the early months, but even the kind of middle period of the pandemic, information about how people were responding. So we created a section for our website, which you can still see there. We're just about to do some updating. And it was all about faith communities in COVID. And on that, we carried the key government advice, but we also carried lots of information about different types of initiative. So there was a section, for example, on bereavement and one on funerals. There were sections on social action. And we made sure that at all our category meetings, all our membership meetings, so all the meetings where local groups came together and national bodies, there was a chance for people to share good practice. Everybody did it differently, and some people fed in a structured way into local authority consultations, etc., or national ones. As you'll know, within the southeast of England, local groups did many different things, and there wasn't a set pattern. What there was, the consistent factor was people's commitment and inspiration to help others and to deal with very difficult issues, but how they did it varied, and we didn't have a fixed template. We just tried to share information. I don't know if that's quite what you were, I don't know whether that answers the question, Emil.
Yes, actually it did. Thank you very much.
Thank you.
Thank you, Harriet. I had one question from Crawley Interfaith Network. Regarding Jason Mather's report, was there any attempt to compare research in Crawley and the Southeast region with other parts of the country? So Jason, do you want to answer that one, please?
No, we didn't. That wasn't within the scope of the project that we were commissioned to do. But I know that in terms of a region, the comparative pieces of work were delivered at the very same time by Brighton and Hastings, so that they could get a regional view of what was going on. I think the NHS commissioners compared those reports and consolidated them into a final piece of work, but that wasn't the scope of what we were asked to do. We were asked to focus solely on community engagement in Crawley.
That's great, thank you. I think we've got a couple of questions coming in through now.
Yes.
On the chat. David and Emma, it's all right, I'll take these ones from here.
Okay. All right, thank you.
There's one from Stephen to Jason. From the 999 experience, what actions can we take? Posters, languages, etc., use of interfaith groups to acquaint minority families and individuals with key societal assistance available, 111, 999, prescription season tickets, libraries, museums, etc.
So what we are doing locally ourselves, that we're very much as a result of doing this piece of research, remember it was a one-off short piece of work for us, but we have found the funding to continue the conversations with all the system leaders in Crawley. I take part in PCN meetings with the health and social care at Crawley Borough Council, where we focus on issues where access may be a problem. We talk about it all the time at the advisory group, and all of the insights that we get, we are feeding into the system at those meetings on a very local level. And I think that the communities can see for themselves that we are actively doing that with and for them, and that is making a difference. We've gone to the community and asked them to translate materials. Does this make sense to you? We've been corrected many times, so it just shows you the value of going to the community to test a theory before you roll it out wholesale. So from my point of view, I think from what we can do, we're passing the information up into the system that we are getting from the communities. We're not editing it, making it more palatable. We are giving it to the system from the source, and that is building trust, and people can see the difference, I'm sure.
Cool, thank you, Jason. There's a question from Ayaz to Dr. David Knight. Were NHS staff of different faiths supported, or were NHS staff of different faiths supported to practice their faith during the difficult times?
Yes, they were. In my own trust is the only one I can speak for definitively at the moment, although data will be gathered over time to show what the national picture was. But in my own trust, there was a very strong awareness from the senior leadership team right the way through the organisation that the practice of faith was crucial in generating resilience in staff who were facing unprecedented challenges, and in the early stages who were just downright frightened, going to work afraid of what might happen to them. And so the practice of faith was not only recognised as important, but was actively encouraged. And a couple of things immediately spring to mind. First of all, that the chapels and prayer rooms in our various hospitals across Sussex, which are normally public spaces, but which haven't been during the pandemic, were redesignated as exclusively for staff use, for quiet time for prayer, for meditation. A second thing was provided by external bodies, which is a number of authoritative organisations, teaching groups within Islam here in the UK and in England in particular, gave clinical staff, frontline ward staff, partial exemption from the Ramadan fast, which was just wonderful and really appreciated, because kitted out in PPE all day, you lose a lot of liquid. And people were encouraged to remain hydrated, and that wouldn't impact on the observance of the Ramadan fast or the exercise of their faith. So support for faith, both from within the NHS and from without.
That's great. Thank you, David. There's another question from Sarah Gill. Sorry if I'm pronouncing your name wrong. She's the spiritual support lead hospice on South Coast. Thank you regarding the Rcn report and the pain we inadvertently caused based on science. I know I struggled that visitors were enabled at the very end of life, i.e. often when people were less conscious and less able to communicate, were very hard to support meaningful time together before that point. What are your ideas post-reflection to not repeat and be led more by spirit, breath, love, rather than the rational science, bearing in mind fear is a strong driver?
Thanks, Sarah, and hello. We know each other. The use of science, I think, is to help us to find a balance in risk. Science can help us mitigate risk to do what we need on a human level at the end of life. So I don't see I'm not necessarily seeing a science, love, peace, spirit-led dichotomy. I think the way science is used can create a problem. And clearly what the Rcn reports and other professional bodies reports have indicated is that we overstated the caution and undervalued the human element at the end of life. And there are ways to find a happy middle ground. The intelligent use of side rooms and controlled access, not open access, but controlled and thoughtful access by key family members. And I know what you're saying about that very final part of the journey when people maybe are less aware of the presence of those who are important to them, and how lovely it would be to introduce visiting a little earlier in the process. That remains, I think, one we need to do a bit of work on, because it's so hard to time how long somebody is going to be in these various stages on this final journey towards death. Are we allowing too much access into wards that need to be, as far as possible, kept protected and contained? I'm not sure I've explained that very well, but I think it's a balance, and it's so hard to find it at the end of life. But I think the intention now is to mitigate the fear of risk and to raise to a higher status the human need to have access to family and friends at the end of life. Hope that answers the question.
Thank you, David. We've got another question for you, and then I'm going to take one more for Jason, and then we'll move on to our other speakers. I'm just conscious of the time, and then we do also want to take a break as well. And I apologize in advance. I think it's my internet connection that's breaking today. It's usually quite good, but unfortunately, it's just one of those things that are out of our control. So Elizabeth asked, did you find that aside from obvious issues of infection and quarantine, did you find that family members of someone who died from something other than COVID were treated differently, almost second class? I've seen people post on Facebook almost apologetically if their family member died of something other than COVID.
Wow, I didn't observe anything like that personally, but I think what will be really important is to gather all these experiences and perceptions and build it into our forward planning for when this happens again, because this will happen again. And work such as that being undertaken by Jason, checking in with communities and how they've experienced healthcare during this period, I think will be crucial in guiding future policy. But for myself, I've had no experience that the nursing teams I've supported have dealt differently with people who are dying of different things. I know there's been problems with early detection of cancers because resources have been deployed elsewhere, for example, in the emergency. That's starting to emerge already, but otherwise I haven't experienced that personally. And I'm really sad to hear that people have experienced that.
Thank you, David. Yeah, that is very sorry to hear that. So I'm just going to go to one more question from addressed to Jason. But before I do, thank you for sharing those resources. Please do keep a lookout on the chat if anybody is sharing some resources for you. I know Zarina's mentioned she's doing some work, so maybe Jason and Zarina, you want to connect later. And so, yeah, question to Jason from Ashwin. So basically asking what you're doing with all this information that you've gathered.
I think I said in the previous question, we, of course, we're sending it back to our commissioners, but part of the deal was with the commissioners that it would always be shared with the communities and anyone who took part in the research and any system leader that we have influence with. And that's been wholeheartedly embraced by the NHS, I have to say, unreservedly. And I think they can see the value. I'm sure they've always known the value of the community voice, but I think they've seen a group of people mustered, and they've seen that conversations are happening, and the insights are being shared, and I hope they are of influence. I think the community in Crawley has a much stronger voice as a result of not just this piece of work, but other initiatives across Crawley that are giving the communities a much stronger voice. And I know that the system leaders are listening. They are. More than that, I'm not sure what we can promise to deliver, but we will continue to champion any kind of inequality. That's part of the core work that we do here at Citizens Advice, and we will keep feeding all of our insights up the ladder.
Thank you, Jason, and thank you, Harriet, David, and Jason. If you're able to stick around, please do. There might be questions later for you. Let's move on to our next set of speakers who are covering the care element of today's conference, which is the first speaker is Dr. Suhil Bhatti, who is the Director of Public Health from Slough Borough Council, and he's going to be talking about how care was supplied by the health sector in Slough during the COVID crisis. So when you're ready, please.
Okay, I hope you can hear me.
Yep.
Okay, in the name of the Beneficent, Most Merciful, I start with an apology. I, first of all, didn't get the Zoom invite for this until fairly recently, or maybe I was zooming in on the wrong connection. And secondly, I only started in Slough on the 2nd of August. So it does feel a little bit presumptuous of me to talk about the care provided in Slough. However, prior to that, I was the Director of Public Health and the Chief Medical Officer for the Overseas Territory of Gibraltar. And we had initially a fabulous response. I feel that I might, by way of analogy, speak about how things happened in Slough and compare them with how things happened elsewhere, because I feel a little bit better qualified to talk about what I lived through rather than what everyone else lived through. We certainly identified the risk from Wuhan in the 3rd week of January, which I believe was roughly when Defence Medical Services and intelligence services in the UK identified it, roughly about the same time. But what I was able to do was to inform the equivalent of COBRA very early on, and was able to persuade our cabinet that this was a serious condition. At the same time, I believe in the UK, it was being denigrated. It was being regarded as a little bit of puffery. It wasn't expected to be as serious as this. What that meant was that in terms of the response that we had, I was able to persuade I quickly identified it was the elderly, people over the age of 70. I've got to be careful as I approach that age myself. I'm going to stop talking about the elderly and to start talking about the 70-year-olds or the wiser people. But what we did was we closed off our elderly people's home the only one was one. We shut all entry to it very quickly. We moved everyone that was in hospital to it, and effectively we made our elderly care homes, residential homes, into a hospital for the elderly. So we moved resources there. We agreed that people would not go out into hospitals if they felt ill. They would have access to ventilators. In fact, we didn't have that many ventilators, so it was CPAP, the respiratory assistance that we now know is really beneficial. And we provided a medical team basically to provide care in that setting. We also took provision to close our frontier. For those of you who don't know Gibraltar, it has about 11 million visitors a year. So even though it's only got 40,000 people, it's got a thriving port at the head of the Mediterranean, an airport, and 11 million visitors. So we shut our frontier. I was surprised at that stage that we even took that step. I thought that the politicians will balk, but there's a very connected small community, so people felt that the loss of one life was a loss too many. And then what happened was, like everywhere else, we had the hunt for PPE, which is the protective systems. Now, here, Brexit had actually helped us. We actually had stores that were already in place and we could use them. Whether they were functional or not is a different matter. And like everywhere else, we went on a hunt for ventilators and soon discovered that there wasn't the huge supply of ventilators that we thought. And I still have nightmares of a big tanker turning up with 40,000 ventilators on it, because we went mad and tried to order them from everywhere. We opened our own Nightingale Hospital, which was done in fantastic short order. We in about 5 days. We also set up our own public health laboratory to do testing. And actually at the initial phases, we didn't have any testing facilities. We were down to 60 swabs at one stage, and it was taking 5 days for the results to come back. So we quickly improved in our capability to do that. I think the same sort of journey took place locally, that the infrastructure had to be set up. What then happened, unfortunately, was we did not have any treatment in place, but because we had a very effective lockdown, which started in the middle of March, at least 3 weeks, I think, before the UK, and lasted for 2 months, we had no deaths whatsoever right until November. And in fact, that I became a victim of my own success. People believed that this was not a serious disease. They could see it on television, but they didn't quite understand that it had an impact. Now, as I say, in the UK and in Slough in particular, people were obviously seized by fear, as Dr. Knight said, that the unknown is a huge problem. I myself was on a journey. I followed the WHO advice, which said masks are not important. And then about May, I said, I'm sorry, I'm now convinced that masks are important. This disease looks like it is airborne. And one of the reasons that the system resists airborne transmission is it has such huge manifestations in terms of needing to be protected. We spent an awful lot of our time doing cleaning and cleansing of various surfaces, but actually the evidence so far has been very little has been transmitted through transmission through surfaces and touch. It's nearly all been done by airborne transmission. So we did eventually, unfortunately, get a few deaths after an outbreak in our nursing home, which was almost inevitable. What happened, I think, towards the end of the year, and I think this is manifest everywhere else, was people had a lot of COVID fatigue. They wanted it over and done with. They wanted to meet and greet their loved ones. They said, what kind of existence is this where we can't see our loved ones? They are becoming more demented because they're aging visibly before our eyes. They're not doing the exercise. The old ones, I'm afraid, were also very, very frightened of this disease that could strike out of the blue. And so we put in place, like everywhere else, and I'm sure we touched on it, a system of support for people to live at home, the delivery of food and provisions and other necessities. And actually, in many ways, that became a very important part of community development, because we all pulled together against a common enemy. It's only when the situation started to break down again, when it looked like people funnily enough, for a lot of the festivals like Hanukkah and other Jewish festivals, the Hindu festivals, the Muslim festivals, the Eid, people were quite understanding of the fact that they didn't and shouldn't mix. But when it came to Christmas 2021, there was just general antipathy towards it. Nobody was prepared to tackle, politicians weren't prepared to tackle the bad news that they would need to give out, which meant, unfortunately, lots of Christmas parties. And in Gibraltar, we had a huge spike of cases, 94 deaths for a size of population of 40,000. It's on a par with the UK. I would also like, and we had the same experiences of end of life care. I was asked on a regular basis, people wanting to wish their loved one goodbye. And unfortunately, the really difficult decision was that if you introduce someone into a sterile setting, you are also making it more difficult for the staff to be able to work, because they themselves are exhausted and wearing PPE and having to change things, and they have to teach someone else how to do things, not because they don't want to do that, it's just they're exhausted. And that's one of the overriding things that I think is worth emphasizing, that healthcare practitioners now are hugely exhausted and burnt out. And we will begin to see, if we're not seeing it already, a sort of loss of experience. Most of our older people are going to leave, and our younger people are talking about moving to other jurisdictions where they may be more valued. That's going to be a lasting legacy. I should also say that this is my fourth pandemic. Many of us think pandemics don't happen. All of us will have heard of the AIDS pandemic, which has killed 30 million people. And obviously, some of us have heard of the 2008 pandemic, which most people thought was a damp squib, but actually a lot of people died in that, but it wasn't a big bang. And there was also the 1968 pandemic of flu, where I was a young lad, but I did remember seeing lots of grainy pictures of people filling hospitals up. So pandemics happen, and they happen regularly. And as the population of the world increases and is more connected. I'll give you one example by anecdote. Gibraltar, you would think, had nothing to do with China when it broke, but in mid-February, we had a visit from the Wuhan football team. So a small place like Gibraltar attracted someone from Wuhan. That's how interconnected we are as a global community. And that means that any infection that can find its way to human hosts and has any chance of spreading is something that will attack us. And therefore, having our community immunity is important. You go back to medieval times, you will see the hits from the plague and other diseases. They were often, villages and towns were often protected by their religious leaders, who would quarantine the whole village or town as a way of protecting. Again, being in southern Spain, I saw an awful lot of evidence of that historically, such that some people were still wearing shrouds in places like Jerez de la Frontera, even centuries after there was no faith and there was no infection, because it became so imbued into the culture as a protective mechanism. I'm sorry I can't speak about Slough, but I think the questions of end-of-life care and the tragedy that entailed and the restrictions that we had to put ahead were to do partly to protect our staff and partly to protect the relatives themselves from it. Yes, we could probably have done better. Certainly in Gibraltar, we allowed one relative in, but someone had to make a judgment about how far that person was from expiring. And then we also had truncated some of the religious ceremonies around it, the washing of bodies, etc. We had to put in some restrictions, but we tried to be as sympathetic as possible, because we understand Gibraltar's a 70% Catholic population. It still has the habit of burying everyone within the day. So that was one of the interruptions they did not like, because we had to ensure there was no nefarious business taking place. Someone didn't die of something else and attributed it to COVID, so everybody had to be swabbed and checked to see if they died from COVID. We didn't require postmortems, but we did introduce CT scanning of the dead body so that we could retrospectively go back and produce and provide succor for people who perhaps had doubts. And keeping in mind the symptom complex of COVID could involve all blood vessels, so you could actually die from multi-organ failure, you could die from heart failure, you could have a stroke. They could all be related to COVID. So we also introduced two variants, which was death from COVID, where COVID clearly was the agent that caused the death, and death with COVID, which meant that COVID was an incidental finding that may have been enough to push someone over the edge of life, but was an incidental finding, not a main finding in all of this. And we put in a medical examiner system. We did not use because it's a small jurisdiction, we could actually measure each death. We did not introduce, it's got to be within 28 days of testing positive, etc., which I think, unfortunately, is a systematic attempt to create capacity when there isn't really that much capacity to clearly identify someone who did die from COVID or with COVID, but is using the fact that there was a positive test 4 weeks earlier. So I do apologize to people. I'm more entitled to talk about Gibraltar. I think you will see there were significant analogies in any of your regions, both about PPE, about symptom complexes, about exhaustion in staff and the exclusion of people. But I know that by protecting the elderly early on, we saved hundreds of lives. And actually Gibraltar passed a law which made it illegal for anyone over the age of 70 to go out without justification. They were going out shopping, etc. And I remember standing next to the chief minister, who said he could not believe that he was doing this in his lifetime. But that actually, I think, saved at least a third of the lives we thought we might have lost at the beginning. So I'm happy to take questions as much as I'm able to. I do apologize that I'm not an expert on Slough, but my predecessor left. So I'm hoping that my expertise in infectious diseases, epidemiology and public health may, at least in a general sense, provide some added information. Thank you.
That's great. Thank you, Dr. Suhil Bhatti, and especially for filling in like that. You are new to the area, but thank you. We appreciate your time in today's conference. I'm just going to change this program around slightly again. Lawrence Gamlin has joined us, but unfortunately he needs to go for a funeral, and I don't want to put pressure on him because he's the time constraints. So I'm going to put Lawrence on next, and then we'll hear from Jamie if that's okay with everyone. So Lawrence, when you're ready, please.
Thank you, Kautha. Good morning, everybody. My name is Lawrence Gamlin. I'm the spiritual care lead for Ashford and St Peter's NHS Foundation Trust, and Kautha has invited me to talk about my personal experience of loss during COVID-19. I wasn't sure how to structure the 10 minutes I've got or to walk us through that time together. And I eventually settled on, I think, an introduction, which is a bit of a general ramble, and then to offer you some bullet points concerning losses that I've experienced, but in no particular order. Some may well resonate with you, others might not. And then I'm going to end just with a couple of personal reflections. So this is all very subjective stuff. So in no particular order, personal losses due to COVID-19, a loss of my own health due to catching COVID in the first wave and fairly early on, the loss of my partner's health as she caught COVID and got it worse than me. Next loss is of a holiday, as my son, who lives with us, contracted COVID-19 the day before my wife and I were due to go for a well-earned, long-delayed holiday, and we had to self-isolate instead. That was just, and the irony of that is a couple of weeks before the guidelines changed. Other losses, a loss of my composure, as with trembling hands and thumping heart, I donned full PPE for the first time, to attend a patient who was dying on one of our ITUs. The next one, a loss of members of the faith community that I lead, who don't yet feel confident in coming back to join us for public worship. The next one is a loss of certainty in times of knowing what I did and how I did it. Like many, I much prefer order and predictability in my work. And when the pandemic was at its height, I lost both. Next loss is a loss of volunteers, those who visited our patients in our hospitals. It meant that I was hard stretched as, together with a Catholic priest, we attended to the spiritual needs of our patients. Usually that's a ministry shared with a minimum of 12 other people. A loss of control over my time. That just seemed to go completely out the window. Just two more losses. A loss of focus in my work on occasions, and on one particular occasion, a loss of my temper and a temporary loss of God. During the first two waves of the pandemic, we treated about 1,600 patients with COVID. We went from 1 intensive care unit to 4, and we're very close to opening a 5th. We treated the 1,600 and we lost just over 500 to COVID-19. And I lost count of the times that I sat and prayed with those who were dying in our care. And others have already alluded to what sort of experience that was, with the relatives only being allowed in towards the end of the first wave for an end-of-life situation. Let me now share two instances that particularly affected me. The first is the story of a family friend who contracted COVID-19 despite being scrupulous in following the guidelines to the letter. This person is a parent in their early 40s, 2 small children, and a partner who uses a wheelchair. I was called into our intensive care to spend time with my friend, who was being prepped to be ventilated. Such was the acuteness of the situation. It was quite likely that my friend would not survive. I was the last visitor that my friend saw. At the time, this person was fully aware of the seriousness of her situation, struggling for breath, but fully conscious. I could see the look of plain and utter fear in their eyes. And as we held hands, I sensed the grip tighten considerably. My friend has faith, a Christian faith. We prayed, and I used the familiar words of Psalm 23, "The Lord's my shepherd, I lack nothing, makes me lie down in green pastures, leads me beside quiet waters, refreshes my soul, guides me along the right paths for his name's sake. Even though I walk through the darkest valley, even the valley of the shadow of death, I will fear no evil, because you walk with me. Your rod and your staff, they comfort me. You prepare a table before me in the presence of my enemies. Anoint my head with oil, my cup overflows. And surely your goodness and loving kindness will follow me all the days of my life, and I will dwell in the house of the Lord forever." And as I recited those familiar words, I recall saying that I would see my friend on the other side, which I thought was a suitably vague, but possibly a comforting word for my friend. A few days later, I was able to see my friend again as the ventilation was reduced and she was able to regain consciousness again. I felt so uncertain and so wobbly as I walked away from her bedside that morning. And it was 10 days later that I received the call to return to my friend, who had been brought back from the brink. And I was able to walk on the journey to our specialist recovery ward. A few days after that, I was able to take my friend back to their home and family. Recovery's been slow, far from complete, but is doing okay. So that's the first little incident that I wanted to share with you. The second, some weeks after that experience, I was on a Zoom call with some local Christian leaders and our area bishop. I recall being shattered and aware that I was running on empty at the time. I hoped that there may be some support from fellow ministers, so I joined the call. We were invited to think about the blessings of COVID. I could scarcely believe what I was hearing. Fellow ministers talked about their online services and how many were tuning in to listen to their meetings. Others spoke of how they'd been able to find new ways of serving their neighbours. The mood was definitely upbeat and a million miles from where I was. When it came to my turn, this is another loss, I lost it. I said that from where I was standing, I could see no blessings of COVID. Instead, I saw patients die and families bereaved. I saw healthcare workers on their knees with exhaustion. The virtual room went a bit quiet, and I felt the tears fall as I recounted my experience of brokenness and inadequacy for my work, and the volume of hurt that I was working with. People nodded in sympathy, those who kept their cameras on, but I can't help feeling that people had thought that I'd lost it, and I just didn't understand. The Christian tradition talks about the need for death in order to see and experience new life. During this pandemic, I've gained an insight, I think, into what that means, a new insight. There is a time to think about blessings and hopes and stuff like that, but there's also a time just to sit and weep and to recognize and experience those feelings of desolation, isolation, abandonment. It's what the founder of Christianity experienced as he walked this earth. And in that moment of separation from my ministry colleagues, I felt held by Christ and that he did understand. So as I come to the end of my little ramble this morning, I'm left reflecting that despite the pain, there is privilege. I was so acutely aware of being in a privileged situation, scary though that was. For new life to come, the old does have to die. And somewhere in the middle of that dynamic, in the darkness and the brokenness of it all, God is. Even though I walk through the darkest valleys, I will fear no evil, for you are with me. Your rod and your staff, they comfort me. So thank you for an opportunity to share something of my personal loss through COVID. And bless you all in what you get up to and what you do. Thank you, Cortha.
Thank you, Lawrence. That was really touching, and it really gives us a different angle to think about, and I'm sure there'll be lots of questions later. Our program is completely jumbled up. I'm going to now come back to Jamie, and what we'll do is we'll hear Jamie speak, and then we'll have a 10-minute break. And in that 10-minute break, you can send in your questions. And then after the break, we'll have some other questions, and then we'll hear from our other speaker who's going to talk about personal loss, Dr. Zephyr. And then hopefully we'll hear from Joanna Collicutt in the afternoon as well. So let's move over now to Jamie Green, who is chairman of Slough Council for Voluntary Services, and he's going to be talking about how care was organised by social organisations during the COVID crisis, introducing the model One Slough. So when you're ready, please, Jamie.
Okay, hopefully you should all be able to see my screen now. Yeah, that's sharing okay? Just give me a nod or a thumbs up. Yeah, brilliant, thank you. So Sohail, I'm glad you didn't talk about Slough, because otherwise I'd have been stuffed. I did have some stuff with Gibraltar myself during the pandemic, where my 3 tickets that were for me to go and visit my family in Estepona were cancelled. So interesting to hear about what actually happened there. So I'm Jamie Green, I'm the chairman of Slough CVS, but this is not at all Slough CVS's story. This is the story of Slough and all the community groups in Slough and how they came together, as well as working with all the statutory organisations and businesses in the town. So 2 weeks before the lockdown, I was invited to the first meeting of what came to be known as One Slough Community Response Hub. There were 6 of us in the room, Voluntary, Faith Community Sector, Local Authority, Clinical Commissioning Group, NHS Frimley, Thames Valley Police, Public Health Slough. And we also had on the call, on a speaker on the middle of the table, the Mayor of Estepona in Spain and his colleagues that were working with him, because those other countries were in advance of us on this. They'd already had things happen in their country, so we wanted to find out what was the most important things that we needed to do. And as Sohail alluded to, it was looking after the elderly and vulnerable, and that came across very clearly in that meeting. So we decided that we really needed to work together with others in the town and find a way to protect our most vulnerable and keep them safe, and that really formed our mission. So our mission became, we will do whatever it takes to keep our most vulnerable residents as safe as possible during that dangerous time. And we did that united under the One Slough brand. We needed something that would bring everyone together. No egos, no logos. We worked for our residents, we worked for our town, and we were One Slough. We still are One Slough. Everything COVID related from that point on that went out through our social networks, etc., was all under the One Slough brand. So there was no confusion. Everyone was all going out under the same brand. So it became a trusted brand, and people then understood and knew that One Slough was the place to go to for COVID related information locally. We really knew that we had to coordinate the voluntary sector, the faith groups, the statutory sector and businesses all together in a way that hadn't been done before. If not, what was going to happen was everyone was going to try and do the same thing separately, which just wouldn't have worked as well. So we started a weekly voluntary sector forum. It was launched in March. We had 55 community organisations on that call, and it was a call where there was a little speaker in the middle of the table. None of this Zoom business, we hadn't got there yet. There were about 7 people physically in the room, and unlike the first meeting where we were sat all around the table, in this meeting we were sat as far away from the table as we could possibly be with our chairs against the wall. The world was becoming a bit of a scary place. Our residents were getting a little bit scared, and everyone needed something to reassure them that everything was going to be okay. So we held weekly meetings. We've had an average attendance of 25 groups a week over the first sort of 6 months. The meetings were led by Slough Borough Council and Slough CVS together. And this was really important that it was seen to be jointly led. It brought in the buy-in of all the community groups, all the faith groups, and everyone behind it, because it wasn't the council telling people what to do. It wasn't anybody telling people what to do. It was the CVS and the council together saying, this is what's happening, this is how you can help. And we coordinated people around their skill sets to make sure that the things that they were good at could happen. So we put together a community response phone number, a call centre. Everything was done from one central source. So there's one phone number, one email, one referral form. Everything then fed into a database of vulnerable people, so that when people needed something and when people were offering services, we were able to match them very easily. So responding to the imminent need at the start was all about access to hot meals, food parcels, vital medication, building resilience in the communities, wellbeing calls, stopping loneliness through regular chats, and we had multilingual volunteers on the lines to do that. Now, this was all done through partnership working. We were able to coordinate the response quickly and safely using volunteers from existing community and faith groups. And it was really important to do that, to work together and make sure that we worked through the one channel. Everyone was working with One Slough, so nobody was going off and doing their own thing. It was all coordinated, which meant we were able to reach many more people than we would have done trying to do everything on our own in our individual groups. The other advantage we had of working with the groups was a lot of these groups had various skill sets that we would be able to tap into. DBS checks were already relevant to some of the groups. So where you might have vulnerable people, you were able to send people that had already had DBS checks and had safeguarding qualifications out to those people to help them with whatever they needed, which meant that we didn't have to try and find people. People were already there. We knew what the skill sets were of the various groups, and groups were coming forward and letting us know what they could do with us, it was just an amazing time. One of the best things I've ever been involved with so many people asking how they could help. It was a very humbling experience. So obviously at that time, lots of people were furloughed. So our call centre was set up by voluntary sector staff who provided the training. Community kitchens were working with furloughed chefs from Heathrow to create food, and the food was obviously of high quality and high nutritional value. These chefs are usually working in 5-star hotels, and then the foods were donated from communities and businesses and also faith groups as well. Faith groups provided kitchens where chefs went in and took over the kitchen to create meals for homeless people, but not just homeless people, anyone that had COVID usually also needed feeding as well, because a lot of people had COVID and then couldn't look after themselves or their families. So networks of people came out through this, where we would get food from the faith kitchens, give them to one of the local community groups that would normally feed the homeless. They were going out and feeding the homeless in the daytime, but also in the evening, they were taking out food to people who had COVID, so that those people and their families had at least one hot meal a day. Really, really important that that happened. And it was just so amazing, the offer that we had. And it was not only the food was, you know, culturally relevant, it was that it was nutritionally good as well, which, you know, makes all the difference when you're not well. So I've mentioned food quite a lot, and we know that feeding people was one of the biggest things that we needed to do. Yeah, it was vital to our community's resilience. It was the #1 request on the helpline. It was food related issues. Some people weren't able to get out and go to the supermarkets, so we might have to do their shopping for them. Some people just weren't able to make the food for themselves. One of the most important things we did with the homeless group was make sure that the food got to them. Other towns were doing voucher schemes where they were giving homeless people that were staying in hotels vouchers to go to Tesco's or Sainsbury's or wherever. And that doesn't mean that they're necessarily going to buy food when they get there. So we wanted to make sure that people were actually getting the food that they needed. And that really was reflected in the way that the homeless people over time became, having had food of high nutritional value food, and perhaps not doing some of the things that they were normally doing, became much more healthy, and their well-being was much better. So I'm just going to end on this slide, which was from the first 11 weeks, which really does show what happened locally with everyone joining together and working together. And there's some amazing stats on here. So 5,621 prescriptions were delivered to people, and that was done through community groups going out to the shops, faith groups having their volunteers go to the shops, go to the pharmacies, pick up the prescriptions, and then take them either to the place themselves, or the prescriptions were picked up by a local community transport organisation. 972 families supported with food on a regular basis. 70 emergency food parcels delivered, and those emergencies were really like just an overnight thing, just to tide someone over till the next day, whereas the 972 was more of a week package that would see a family through the week. Food Bank looked after nearly 2,000 during that 11-week period. Nearly 15,000 hot meals were delivered to vulnerable people, NHS, police and key workers during those 11 weeks. And that really was about those faith kitchens and community groups all working together to distribute everything that was being cooked. And again, non-perishable food parcels being delivered. And some of that was from volunteers going out shopping, and then the community transport delivering the shopping to people, and others was from food banks that were made up in various faith locations as well. All in all, for me, working through the pandemic with that team of people and watching the community groups come together, it was one of the most humbling things that's ever happened. It's still going on now. We're still working with One Slough as a brand. We have embedded it into the local vision for 2040. So it's amazing to have the organisation that came out through COVID is already actually in our 2040 vision for the town. There's a business plan, we're strengthening the infrastructure. We now have a vulnerable database of people in Slough who are vulnerable, so that we can actually look at helping them before they get into more problems. So there's lots of things we can do for our vulnerable people now that we couldn't do before, now that we have that database. The steering group is still around, and it's all leading towards localities and strong and healthy and attractive neighbourhoods in the future through all these organisations working together. And actually, we've cut out a lot of red tape with One Slough. Things that were needed during the pandemic just happened. So I'll give you an example. The vaccination centre in Slough. In about the third month, when we started getting more people that were driving themselves, we were running out of car parking space and backing up the cars onto the A4. So we raised it as a One Slough issue. I spoke to the council about creating an extra car park on the site of the Sohail Park Centre. Within a couple of days, we'd worked out where the car park was going to go, and matting had been installed in the park so that we could get an extra 40 cars in, which was just enough to keep us trickling over and making sure that people got vaccinated. And that all happened just over the course of a couple of days without any red tape. And if we'd have tried to do that in normal times, we'd have probably had 6 months of meetings before we'd even put a spade in to do something. So the One Slough way of moving forward with all the community groups working together, cutting through red tape, has been absolutely amazing. And hopefully it's going to continue for a while with that methodology of working together and cutting through red tape and making things happen that just make sense. So it's been fantastic to work with those community groups and faith groups. And we just hope that all those links keep going beyond the pandemic as well. Thank you.
That's great. Thank you so much, Jamie. That was amazing, really amazing work. And I think that sort of work probably resonates across up and down the country. So thank you for that. I don't know about everybody else, but I need a break now. I'm sure everybody else needs a break. Let's have a 10-minute break, and you can send in questions. Emil and David are looking through your comments and your questions, and we'll address them when we return. So 11:36 now, so let's say 10 minutes, 11:46, bang on, we're going to be back and start. See you in 10 minutes.